So let's move to the second topic, CML as a second malignancy. And it's my pleasure to introduce, it's not the time to introduce, you've already contributed so much to the discussion, but let's take the time to introduce more formally Professor Ehab Atallah from Milwaukee in the USA. And it's on my script here. He is a giant in the CML field. He is Professor of Medicine and the section head of Hematologic Malignancy within the Division of Hematology and Oncology at the Medical College of Wisconsin in the USA. Welcome, Ehab. It's a privilege having you here. Thank you so much, and also for your contributions to the first topic.
Thank you, Stephanie. And more importantly, that I was raised in Nigeria and Egypt, but I was raised in Nigeria in the first few times of my life. So I'm African.
Yeah, so you are both African and international expert in one person. Wonderful. Thank you. And then, unfortunately, we don't have a picture because, as far as I know, Dr. Ahmed Ibrahim Oluwaseun, I hope I pronounce your name correctly, you have kindly sort of committed to present, I think, at the very last minute, so we don't have a picture, unfortunately. You're from Nigeria and a consultant hematologist at the Obafemi Awolowo University Teaching Hospitals Complex in Ile-Ife in Nigeria. Dr. Ibrahim, he comes highly recommended by his colleagues in Nigeria and has stepped into this particular topic, as I've said, as short notice, for which we are very grateful, and we look forward for him sharing his knowledge with us today. Due to technical difficulties, we didn't have the time to check his slides, so I stopped sharing, and please feel free to share your slides. Hopefully it's working well. You should be able to share your slides now. Wonderful. Okay. We can see your slides, not yet in presentation mode.
Okay.
Looks great. Wonderful. Thank you.
All right. Yeah, thank you very much, Stephanie, for this opportunity. Thank you, Professor Atallah, for joining this discussion. It's a pleasure having you around. Yeah. So I'll be presenting the management of CML coexisting with non-Hodgkin's lymphoma. This is one of our CML patients that presented with double malignancy, and currently in Nigeria since 2003. So we've had the opportunity of assessing tyrosine kinase inhibitor via the mass access solution. So, and up until January this year, so our hospital, Ile-Ife, that's Obafemi University Hospital, has been the only center until January this year when the program was decentralized, and then we have another center, in the capital of Nigeria, that is in Abuja. So currently we have close to 2,000 CML patients in our care. So, and this is one of them, and I'm happy to share this case with you. Yeah. So, and one of the major challenges, yeah.
I'm sorry for interrupting. I was not sure if the slides are working well, but I think now the slides are moving. I'm sorry for the interruption.
Yeah. So one of the challenges we have in our care, in our patients, is that most of them present very late. And this was shown by our publication last year, showing that majority of our patients actually presented very late, and that eventually affected the outcome. So to go to the case presentation proper, so this patient is a 30-year-old Nigerian, a university graduate at that time, who was referred by the general practitioner 7 years ago with complaint of multiple neck and groin swelling, progressive abdominal distension, and unexplained weight loss. Incidentally, he observed a 12 kg reduction in her weight within the last month. And there was history of progressive easy fatigue, and that became very severe within the last 2 weeks before presentation. So significant examination at presentation. Significant physical examination included pallor, multiple palpable lymph nodes in the cervical and inguinal region. So the largest of the nodes were 4 by 4 cm. Abdominal examination showed non-tender hepatomegaly. This is shown by the CT scan that was done, showing an enlarged liver of 16.9 cm millicranial span. The complete blood count showed hemoglobin, a low hemoglobin of 6.7 gram per dl, marked hyperleukocytosis of white blood cell count of 278,000, and platelet count of 312,000. The peripheral blood film showed hyperleukocytosis with complete spectrum of the myeloid series. Majority of them were band and segmented neutrophils. The peripheral blood and bone marrow aspiration showed features in keeping with CML, chronic phase. Reverse transcriptase qPCR done showed positive BCR-ABL1 with a very high ratio of 63% on international scale. So the transcript detected was E1483. So initially, we made an assessment of chronic phase of CML. Further evaluation, so the patient was sent to the surgeons, and then the patient had an excisional biopsy of the left cervical lymph nodes. HIE staining of these lymph nodes shows features in keeping up with NHL. Further evaluation by immunohistochemistry showed that these tumors were positive for CD45, CD20, but negative for CD15, CD3, and CD30. So these are the photomicrographs. The first one is the HIE staining that shows nodal investment of the nodal architecture by malignant lymphoid cells. And then the second image here is the diffuse cytoplasmic staining for CD45, while this is the cytoplasmic staining for CD20. So a final diagnosis of BCR-ABL1 positive CML coexisting with B-cell non-Hodgkin lymphoma, NABO stage 3B was made. The risk evaluation, for this patient showed that the SOCAL, ASFORD, and the UTO score were both low risk, except the recently approved risk stratification score, that's the UTO's long-term survival score, which was fall within the intermediate risk category. So the patient was adequately cancelled on the nature of the diseases, the rarity of the two coexisting together, the options, the treatment option, and then the prognosis. The option of hematopoietic stem cell transplantation as a potential cure for the two malignancies was also explained to the patient. And then the non-availability of this in our environment, and then the cost for it abroad were emphasized. So we took an informed consent to commence imatinib, and then the patient subsequently commenced imatinib mesylate at 400 milligrams, which was gotten freely by the GPAP program. So, and while we are trying to evaluate to arrive at the diagnosis for the enlarged lymph nodes, the patient, which eventually came out to be B-cell non-Hodgkin lymphoma, so the patient subsequently commenced treatment for NHL. This was about 7 months after the commencement of the imatinib, because the immunohistochemistry and then the other investigation took a while. So the patient had 6 cycles of combination therapy as shown here. And then due to funds, this was sponsored by NHIA through the National Youth Service Corps. So the patient achieved complete hematologic remission within 2 months of the imatinib, and then DMR after 2 years of the evidence by BCR-ABL of 0.01%. So the patient also achieved complete remission, evidenced by complete disappearance of lymph nodes and other presenting symptoms after the 6th cycle of the R-CHOP. And incidentally, repeat radioimmunoimaging could not be done to assess this patient's remission status due to the financial constraints. So we actually relied on the clinical evidence alone. So she was subsequently placed on 3-monthly maintenance of rituximab, and then she continued daily 400 milligram of imatinib. On the social side, the patient presented a plan of getting married. This was after about 4 years on treatment, and then the pregnancy plan was also discussed extensively. As at that time, the patient has had imatinib therapy for about 3 years and then maintained DMR for another year. So she also explained had maintenance subcutaneous rituximab for a year after the initial 6 cycles. So the patient was adherent to therapy until she got married. Sadly, the patient defaulted and then presented 2 years after with a bouncing baby boy. So, and then the other reason for default from her was that she has serious financial constraints since the financial support was already stopped after her youth service. So the complete blood count and BCR-ABL at that time showed loss of hematologic remission and molecular relapse. The BCR-ABL1 ratio at that time was 1.22% from the initial last 0.001%. Surprisingly, after evaluation, there was no clinical evidence of the non-Hodgkin's relapse. So imaging could not be done due to limited finances. Then the patient was counseled on the disease stage. They need to recommend TKI immediately, and then the risk to the baby through breastfeeding. The patient agreed to discontinue breastfeeding and then to choose alternative feeding, and we recommend her on imatinib mesylate at 400 milligrams daily. Fortunately, the patient achieved CHR within a month of recommencing therapy. Our last clinic visit was early this year, and the complete blood count showed a complete hematologic remission. As I said earlier, we have a recently approved center for TKI, so the patient sought for transfer to the tertiary into the TKI center due to proximity. So my discussion points are listed here. What could have been done differently or better? Then, assuming we have enough resources, what additional things will have been done for this patient? What's the prognosis like of CML coexisting with other cancers? Do they respond to TKI as well as general CML? From our experience, what's the prevalence of CML occurring with other cancer types? And then can we consider TFR in patients with CML coexisting with other cancers? Thank you very much for your attention.
Oh, thank you, Dr. Ahmed. So, Stephanie, if you don't mind, if we could go back to the questions so I can try to go through them.
Yeah, Dr. Ibrahim, you're sharing your slides. Would you be able to move back to your previous slide?
Yes, I should be able to.
I think that would be helpful for all of us to read your questions.
So very, very, very interesting. I don't think I would have really done anything differently. I don't think we should ever say better. I think differently would be the word. I do feel very comfortable combining a TKI with R-CHOP because we have very good data with hyper-CVAD in acute lymphoblastic leukemia. So if you combine Gleevec, imatinib, or dasatinib with R-CHOP, we pretty much have good safety data there. So I would have had no issues combining both. There would be no indication to transplant. I don't specialize in lymphoma. I do leukemia only, but I still keep up with lymphoma a little bit. There's pretty good overall survival with R-CHOP. If I remember right, it's in the 60-70% range of a long-term survival with R-CHOP for lymphoma. So I don't think there's any indication for transplant there. Your other questions on CML and coexisting other cancers, that's
correct.
really
Your question. Well, you break the chain and you lose all the money in that chain. But if you press your button,
pretty good.
Okay.
So there's very little data about either, CML coexisting with other cancers or someone having some kind of cancer and getting treatment and then getting CML after that. So I'll talk first about that, the people who have some kind of cancer and then develop CML. So in theory, and Mari, correct me if I'm wrong, the secondary CML is not really something that's known outside of Hiroshima and Nagasaki. Like after the atomic bomb, like 15 years later, there was a slight increase in CML. But CML is not one of the common cancers that occurred after treatment for lung cancer or breast cancer, etc. In my institution here, we had a very, very small series of 7 patients, 7, not a lot of patients, who developed CML after malignancy. And for whatever it's worth, they didn't respond well to imatinib. They responded better to a second-gen TKI. But that's in patients who had a cancer, got chemotherapy, radiation, and then developed CML. The story here is different because they her CML came with the lymphoma at the same time. So I would not expect her to have any different prognosis from CML standpoint. What's the prevalence of CML occurring with other cancer types? I do not know the answer for that. We have a registry that we're collecting data on right now that will include patients with CML, and then we'll be able to see the malignancies, whether they developed before or after CML. But I don't know the data right now. We don't think that CML increases the risk of any cancer. And lastly, your question on TFR, yes, absolutely. I would have no hesitation in considering TFR in patients who have coexisting other cancers, especially it's almost like you have a bigger reason, because what if they're continuing their other treatment? I wouldn't hesitate to consider TFR in those patients at all. I don't know if Dr. Copeland would want to add anything.
Yeah, or any of the other experts, you're welcome.
Or any of the other experts on the phone.
So just a couple of points on the co-occurrence. I've seen a couple of patients that have had radiotherapy for either breast cancer or lymphoma previously, who maybe 5 to 10 years later have developed CML, so probably related to the radiation therapy. In terms of the prevalence of CML occurring with other cancers, now this is specific to our population, which is a high prevalence of cancers. So within the UK, 1 in 2 of us will probably get cancer within our lifetime. So probably within our population, it may be less for your population, because patients are on their TKI pretty much lifelong for most people. Around half of those people are going to get some other form of cancer probably. So the co-occurring incidence is going to be quite high. But usually you would just try and treat the other cancer type as you would normally. So that would be my view, but we see a lot of people developing another cancer which is unrelated to their CML on therapy because they're on it for so long and they have other risk factors.
Makes sense.
So those would be my thoughts, and definitely TFR if they can. Yeah.
Any other comments on these discussion points? Matilda, do you want to comment? Or
I have a question. I think it's an excellent presentation. Maybe a quick question to our experts here as well. I wanted to know what could be the possibility of this patient having ALL blast crisis at diagnosis, and how what could have been additional investigation to differentiate, because I think we had some similar case last year where it was non-Hodgkin lymphoma, but at presentation, the question was really, was it non-Hodgkin lymphoma coexisting with CML, or was it ALL blast crisis? Yeah, so maybe any thoughts?
So yes, I mean, I thought of that when I saw the case. Dr. Ahmed, could we go back to the flow cytometry? I mean, I think morphologically, It should be, especially if you actually do a full lymph node biopsy, morphologically, you should be able to differentiate. I mean, putting aside all advanced testing, morphologically, you should be able to differentiate an immature cell from a non-Hodgkin lymphoma. And I think looking back, if this was really ALS, if this was really CML and lymphoid breast crisis that was treated with R-CHOP, and now you're like 3-4 years out and she's still in remission, I mean, most likely was non-Hodgkin lymphoma more than lymphoid. But that's a really good question to confirm that this is really non-Hodgkin lymphoma, not an ALL that's presenting, coexisting with CML.
Thank you. I agree with your comments. And we've also come across a few similar patients. And I agree that the most important thing is for the treating physician to make sure that the histology is reviewed, send it for a second opinion. You know, if it's lymphoblastic lymphoma and all, the TDT would be high. And I also agree, if this patient had a lymphoid blast crisis, I don't think the outcome would be the same because those patients don't do well. They may seem to do well upfront, but then if you miss a window of them being able to transition to transplant, then, you know, the disease comes back with a vengeance. Just to also share, I've had one experience where I managed a patient who also had esophageal cancer. And that was quite difficult because of the chemotherapy that the patient was receiving, you know, a platinum base. So she would get really cytopenic. And unfortunately for this patient, we actually thought that she may have had an underlying molecular abnormality because she had all these, she had a thyroid issue, she had, I think, an ovarian issue, and then had just been diagnosed with CML and found to have progressive dysphagia, and then the diagnosis of esophageal cancer. And unfortunately, she succumbed to the complications, you know, neutropenic sepsis in the context of recurrence. But the challenge around that time was mainly trying to balance the cytopenias. I would be keen to hear the experience of the other experts and the colleagues from other countries, especially in African countries, because one of the challenges we get in patients who even don't have double malignancies is the cytopenias, TKI-related cytopenias. That seems some patients tolerate it quite well. Many times you're surprised. It's young patients who are not able to tolerate it, and you have to reduce the doses. In this particular patient, at some point, we actually had to hold her imatinib treatment because of the cytopenias. The other case was a patient who was managed by a colleague and had CML and cancer of the breast. Thankfully, she did well and continues. The breast cancer was found early, and she was able to go through her chemotherapy, have surgery, and is now continuing with her TKI. Yeah, so those are the cases I can comment about. Thank you.
Thank you, Dr. Matilda. I think you're raising a very important question, which I had also wanted to raise for our experts. Cytopenia we commonly do see also in Tanzania, and this is one of the major challenges that we face. So I can just imagine the challenges of treating a patient with coexistent malignancy that requires chemotherapy inducing cytopenia and the challenges. Maybe Dr. Ehab, you wanted to mention something? with regards to that?
Yeah, I mean, depending on how well the patient is responding, what I keep reminding myself that the natural history of disease for CML chronic phase is 5 years, right? So by N of 1 of esophageal cancer, they're having issues swallowing, there's cytopenias. I really erred on the side of holding, like I kind of tell the esophageal cancer people, it's your turn. You do this, and then my turn will come later. Because like there's just too many things. The natural history of CML is long. Esophageal cancer is especially miserable. So I'm softer than you. I erred on the side of holding. To the next question of the cytopenias, we do have some and we all talk about these in meetings, and maybe that's what you're alluding to, is we have these patients that start TKIs only, and you switch them from one TKI to the other, and their cytopenias just persist. Like I just sent a 76-year-old for transplant because she could not take a single TKI because her platelets dropped to like 15 and 20 with every TKI that I shifted her to. And there's no clear explanation why that happens. And then I looked at all the studies that were done of people switching from one TKI to the other, and the one adverse event that was kind of had this cross intolerance across all TKIs was cytopenias. Like the cytopenias just nausea, if you go from imatinib to dasatinib, gets better. Everything gets better, but the cytopenias persist across the AEs. I don't know if anyone else has the same experience.
We do. We have actually just analyzed our paper with regards to second-generation TKI and third-generation TKI. What we have observed, those patients that had cytopenia on imatinib did persist to have cytopenia, actually got worse. And this is majority of our patients actually that switch treatment. We found high rates up to 90%, and this were not getting better. That the patients at the time of switching, they had cytopenia, and that actually did persist with other TKIs. And these are the ones who usually have very poor prognosis. And our assumption currently is that because our patients present late, we are assuming that, or our theory behind is they are presenting with depleted normal stem cell cells, and therefore the TKI cytopenia is more of efficacy rather than true toxicity, because after suppressing the abnormal clones, the normal are not able to repopulate the bone marrow. So that is what we are, our assumption, because when we looked at the cytopenia, this was mostly related or occurring in those patients who presented as high risk chronic phase patients.
Yeah, that's a really important point, which is the cytopenias, especially in the first 3 months, especially in patients that you've presented with this really high disease burden. Those you really have to ignore the cytopenias as much as you can in the first 3 months, as much as you can. The younger patients that you presented that you started on imatinib or ponatinib, those I don't hold at all for the cytopenias. I just keep pushing through, and I repeat the bone marrow after 1 month, and then if they're aplastic or they're responding well, then I hold, but otherwise you just really push through. Another point is, I'm sure you're very well aware of all the lower dose studies with dasatinib, and I wondered if some of those patients, not the high disease burden ones, if you have you done dose adjustments, and has that worked in those patients? Like, let's say after the first 3 months, have you done dose adjustments, and has that worked?
Yeah, I can comment on that. Actually, as you have said, the first few months is the most critical, and sometimes that's when you have the higher drops. One of the things that we've typically done, and I think Dr. Nasser may have put it in her presentation, is part of our restrictions are mainly access in terms of your first line is always imatinib, and then you go to your second line. But the challenge is also you end up doing blind switch because of the challenge of not being able to do the mutation testing. But what we found is sometimes if a patient does well and they're more than 6 months, and you're just having slight neutropenia, you know, maybe the white count is 3, neutrophil of 1. I've actually just reduced to 3 tablets and monitored those patients BCR-able. And I have one who actually consistently does his BCR-able at every 3 months. That's not the typical patient though, and he's okay. The other patient, a younger patient who struggled with imatinib, actually for him, he kept having drug-induced hepatitis amidst the cytopenias. And so we moved from imatinib, tried dasatinib, did low dose, but the only thing that has worked is bosutinib, and he's on 200 milligrams of bosutinib. So I think the challenge just becomes for those in whom we are putting low doses is the trying to encourage the molecular monitoring, if at all possible, even if it's spaced out once a year or every 6 months, so that to make sure we don't miss out on, you know, them sort of losing their response. But yes, so many times switching and then trying to get the bosutinib has seemed to do that, apart from the challenges with the with just having the BCR-able going slightly up, but you do their bone marrows and they are hypocellular with no increased blasts, you know. Yeah. Thank you.
Thank you, Dr. Mehta. I think we have a couple of people raising their hand. Stephanie?
Yeah, we have Dr. Bene, I think you were first, and then Dr. Bolarinva. And I've already also seen Mary raising your hands. I don't know if it's still up to date. Feel free to go next. So Dr. Bene, feel free to switch on your camera and to speak up. Welcome.
Thank you so much. Yes, cytopenias always are difficult to manage, and I've realized that for those who are newly diagnosed, sometimes it can be a sign that prognosis will be poor. And so for me, usually what I try to do, what we've been experiencing, more of thrombocytopenia rather than neutropenia. So we try and keep pushing until they become symptomatic. And so we reduce first, and when we still have the symptoms, then we withhold, but not for too long a period, because we realize that for those who are newly diagnosed, if they stay off or they are not able to take the recommended dose, then they tend to transform easily. So having cytopenias is always a challenge. There are some when you reduce and after some time, the counts come up, and then you give it another go with the maximum dose. Some of them do well. There are others who kind of remain at 300 milligrams daily and still have some remission. So cytopenias are difficult to manage, but especially when it's at the beginning of treatment, it can be very dicey because they tend to transform easily. Of course, if the person has had some remission and starts having cytopenias, then it's also a warning that probably there's some transformation going on. So that would be my take on it. Thank you very much.
How low do you go? Dr. Bennett, how low do you go with the platelets?
Well, unofficially, I do as much as 20, unofficially. But then
unofficially.
that is close monitoring.
Maybe she can
close monitoring and asymptomatic.
Okay.
So that's the unofficial one. Thank
I
you.
agree in the beginning, yes.
Thank
Yeah.
you. Thank you.
Thank you.
Dr. Bolarinwa, do you want to go next with your question? I've seen your hand. Or alternatively, you can submit your question in the chat.
Yeah, thank you very much. Good evening. Hello?
We can hear
Can
you.
you hear me? Oh, all right, thank you very
well.
much. Yeah, I just want to give my perspective about the issue of cytopenia. A hematologist at Ile-Ife. Interestingly, we've seen quite a number of patients presenting with cytopenia upon start of imatinib. Apart from other measures that I've mentioned, reduction in imatinib doses, switch of TKIs, and a few other things. One of the other things that we have also done is the use of TDM. This is a therapeutic dose monitoring, which has really offered a good opportunity for patients. One of the things we have noted in this is that quite a number of patients, we have about a few number of our patients that after doing TDM, we could see that they could do well even on 200 milligrams of imatinib. I still remember we have about up to 3 or 4, 5 patients that are currently on 200 milligrams of tyrosine kinase inhibitor, imatinib to be very specific, which are doing well, very well currently in their molecular remissions. And this has been done for quite a number of our patients. Some of them on 300 milligrams after the use of TDM to assess the level of drug in their that is circulating in their serum. This has been very useful, especially when we are starting a patient on imatinib. We realize that a few of them, usually when they have a very high dose of imatinib in their circulation at 400 milligrams, it quite leads to cytopenia. So if you now titrate your imatinib to the level of what is required, then some of them we could achieve a reduction or a clearance of the cytopenia. This is one of the things that we have been doing. This is done in collaboration with pharmacogenetics units in the Faculty of Pharmacy. Usually we send this patient to them, they will do the drug monitoring and drug level for this patient. So they will advise us on what dose we should place them. So this has also been very useful to our patients. I just think I should give this perspective as a way of tackling cytopenia in patients with CML and tyrosine kinase inhibitors. Apart from these, other things are what have been mentioned, which we have done for quite a number of our patients. Dose reduction, change of TKI, especially some of them that have progressed. Cytopenia could be a reason or a presentation after progression. And when they are changed to other form of TKI, the cytopenia will disappear in them. Thank you very much.
Thank you. That's a really, really interesting perspective. I've done TDM for imatinib very rarely in patients who have like significant side effects, including cytopenias, but it's not a common thing that I do. That's a really interesting perspective. Thank you.
Thank you very much. So we have 5 minutes for this meeting to close, and I've just checked the chat, and it doesn't seem to be any additional question here from the audience. So I'd like to ask all of you from the panel of experts, do you have any final comments on all of these cases discussed or any additional topics you'd like to discuss?
I think it's been a really interesting discussion, and they've been really great cases and great presentations. So I'd just like to thank everyone that's presented and discussed, because I think it's been a really good evening. for the discussion.
I'd like to echo that, and I need to just let Dr. Nasser know, Dr. Ahmed Nasser, to know that with advanced phase CML, if you put 10 US CML experts in one room, each one will give a different opinion. So like it is so non-standardized. No one knows if like chemotherapy is important. No one knows like, should we do both? Should we do one? How much chemotherapy? Dr. Copeland pretty much has the most famous paper in that area with the flag IDA ponatinib. But otherwise, data is so limited in that field. And thank you for this really, really interesting discussion. You guys are like the real doctors. You kind of make a lot of decisions with little information. So pretty amazing.
Wonderful. Thank you so much, Ehab. And I think that's a good final question, because this brings us to the beauty and the value of these discussions, to bring experts from Africa and from international centers together. And to me, it sounded like a very fruitful discussion. I've just seen that we have one final question, and I'd like to bring this in. So if any of you want to provide a quick answer to this question from Ephraim Haile.
Oh.
The question is on the use of GCSF, and also to add on to that L-Trombopag in these patients. The benefit of GCSF in persistent neutropenia in CML patients, and then I'll add also use of L-Trombopag, so that we are not getting to 20.
Yeah. Mari, you want to take that?
Yeah, sure. So we would use GCSF short-term in patients that had neutropenia, but I think if a patient was needing it long-term, we'd probably look to switch them to another TKI, or even potentially consider transplant. L-Trombopag we don't use. I know there are a few case reports, but we haven't used it in our CML patients. We do use a lot of EPO though to support some patients, and that seems to be in particular patients that have had chemotherapy for other malignancies, and also patients that have renal problems. So we do have quite a cohort of patients on EPO, but no long-term patients on GCSF or L-Trombopag.
Thank you.
So maybe additional follow-up. I know we are out of time. Maybe additional question to you, Dr. Copeland. With regards to the cytopenia within 3 months of starting TKI, and also the concerns other experts have brought about that the cytopenia usually it's a sign before transformation. Would you recommend doing bone marrow aspirate first before giving the GCS granulocyte colony stimulating factor for the fear of transformation?
I probably wouldn't do a bone marrow test, but I would do a blood film and look for blasts. And then if the cytopenia was persistent, just despite the GCSF, I would do a bone marrow then. The GCSF is not going to trigger the transformation. It's just going to make it show itself more quickly. So I would definitely do a blood film, but I wouldn't do a marrow unless they'd had the GCSF and they weren't responding, or all the cytopenias were getting worse.
Thank you.
Thank you.
Mine is just to thank ICMLF. I apologize I joined in late, but I want to thank them for their continued effort towards bringing experts both from the various regions and coordinating the meeting with the international experts as well. So thank you very much to ICMLF for being consistent in this call and in this regard. And the sessions are always, there's always things to learn. And then you learn you're not the only one who is struggling. Yes, and the experiences are shared.
Yes.
So thank you very much.
True.
Oh, wonderful. Thank you so much for your kind words. That's really, really good to hear. And then it's my time to thank all of you on behalf of the ICMLF, especially Dr. Nasser and Dr. Ibrahim, for sharing your interesting cases and for contributing these interesting questions, and Professor Copeland, Professor Atallah and Matilda Ngondi for joining us as international and African experts, or both international and African experts in case of Professor Atallah, and for contributing and sharing all your expertise. It was really, really interesting. And in case that there are additional questions from the audience, feel free to contact us at the ISFNF. The email address is info@cmlfoundation.com, and then we can forward your questions to the experts. So in time of any additional question. Thank you to everyone. And before we close the meeting, I'd like to share 2 more additional slides just to announce the next 2 webinars. Hopefully you can see my slides. So we hope to see you again. The next African discussion group is on Wednesday, the 15th of October. You can see the interesting topics here. The first one is attacking TFR in resource constraints settings. And the second one is BCR-able monitoring and intervention, especially slow responders and current guidance. The same concept with a combination of experts from Africa and from international centers. And the third in our series will be held on Wednesday, the 12th of November, with CML and pregnancy in resource constrained settings and overcoming challenges to adherence to therapy. So additional really relevant topics for clinical practice. So hopefully we will see you again. Thanks again to everyone on the expert panel and to everyone who joined this meeting and for all of your contributions.